Every day in the NHS, there are 15 million emails. At least 5 million patient-related emails will go through the NHS every day. 5% of those will never be read. Now, we're talking about 250,000 emails per day. Per year, about 300 million of the 7.5 billion emails will never be read. If only a fraction of those lead to true harm, that's still almost 1 million people. And our software reduces that by 1/3 immediately within 2 weeks, while improving staff well-being. Patient lives depend on email. We didn't go into medicine to become digital or data engineers. We didn't go in with gaming backgrounds. We went in with people background. And so putting that side onto these guys, it's almost gamification. And actually the error rates are going really high. And all of this adds techno stress. You have to do 26 clicks just to get an outpatient clinic visit. Most people in the NHS are stressed if you actually test them on a HAD score. 2/3 of staff were on their email either every minute or every hour. 2 out of 3 said it distracts them from their main work purpose. Air Email is a very simple tool that actually is intelligent automation. Highlight any tasks inside the actual text itself. Try and identify those patient-related emails. Our aim was a 2% productivity gain. Turns out we smashed that. We left 1/3 less emails unread, including patient-related emails. 36% less. For the first time ever, a software led to staff well-being impact with a 13% reduction in anxiety within 2 weeks of using our software. We are the first software in the world that you can go straight from Outlook and go straight to the patient's x-rays or straight to the patient's medical records. The NHS cycle just to get a contract might be a year to get a contract. Can you last the company out for that year while you're waiting?
A barely believable 7.5 million emails sent across the NHS every day. Some about internal matters, but many are about patients, moving patients' journeys forward, requesting diagnostics. As you can imagine, these invariably have an impact on both staff well-being, but also patient care and patient outcomes. What if there was a way to manage these appropriately and in a timely manner so that that impact can be minimized and remain positive? In today's episode, I'm talking to Dr. Ameet Bakhai, an eminent consultant, cardiologist, as well as researcher based at the Royal Free, and also the co-founder of Air Email. We talk about everything from email overload, how delays through missed emails can cause serious incidents, and how Air Email can help solve these issues. So without further ado, let's dive right in.
Hi Ameet, welcome to Inside Health Innovation.
Karina, thank you so much. I'm really looking forward to this.
Yeah, me too. I mean, obviously I've read a little bit about Air Email and I'm so excited that you've managed to make it today. Really looking forward to get started.
Pleasure.
Okay, great. So the way I usually start these podcasts is I always ask my guests the same question. And I'd love to start there with you as well. What does the word innovation mean to you?
I think it's really important that we do understand that. And to me, it's about pioneering to make a positive difference.
Yeah.
I think that's as simple as it gets, right?
Yeah. I mean, it's interesting, isn't it? You can spend a lot of time trying to define this word, but I think you've kind of got to the crux of it in a very short sentence. Yeah, that's really nice. Thank you for sharing that. So let's just talk about you, Ameet, first before we get into the product. So you have had a distinguished career as a consultant cardiologist.
Still in it.
Yeah, continue to have a distinguished career as a consultant cardiologist. But I understand when you first started studying medicine, that's not what you wanted to do. So why and what changed your mind?
That's a usual idea, isn't it? That I was a mathematician. I was doing programming on the ZX81 in those days. I don't know if you ever remember that.
No idea what that means.
ZX Spectrum and the days of Mr. Sinclair, etc. many years ago.
Yeah.
And so got into Oxford to do maths.
Right.
And of course, Mum comes along and says, "You're my only son and only child. We need a doctor in the family."
I like that there's a bit of an accent coming through when you talk about your mum.
And so she asked me to do medicine. And you can't refuse your mum. What you can do is negotiate and say, well, look, I'll do this for 5 years. And if I don't like it, I'll go back to maths and programming and coding in those days. And this was a long time ago.
Yeah. And then what happened? How did you... So when you were doing this 5 years at Oxford, what changed your mind?
I was at Barts because I didn't go to Oxford for maths in the end. I had got into Barts Medical School, which is quite difficult in those days. There were very few of us that were not Caucasian, and lucky to get in. And I was very blessed that Professor Michael Besser actually went to my comprehensive school in Brighton, and so I think that's why he shortlisted me. And he gave me such a hard time at the interview.
Oh, did he?
But nonetheless, we got in. And when I got in, the first 2 years were very difficult because you have to remember so much memory work on Gray's Anatomy and Guyton and Stryker and all these biochemistry and physiology. But once the maths kicked in year 3 for differential diagnoses as to what has this patient got depending on their symptoms, it all became an algorithm.
Right.
And the likely differential that this patient has this, I could even put percentages to it.
Wow.
And the next test... And not only being Sherlock Holmes, you found out who caused the murder, but actually you could intervene before the murder. You could actually help the patient get better because you knew which treatment to give and what the likelihood of benefit was. And so everything became mathematical. So my maths came into huge play in my success in medicine.
Yeah, that's amazing. And I guess that's what made you stay in medicine then, did it?
Absolutely, because now maths had a purpose, helping people's lives.
Yeah.
And who better to do risk assessments than a natural algorithm walking around the wards? And that's what's happening now, digital health, right?
Yeah,
our
absolutely.
algorithms, but we had those in our heads a long time ago. And we always have got those in our heads.
Yeah, I bet you do. That's fascinating. And obviously, as you've sort of gone forward in your clinical career, you're obviously doing a lot more than clinical practice now. So you're involved in research, health economics, and digital innovation as well. What sort of motivated this curiosity to go beyond the bedside, as it were?
So it's always about the barriers to helping patients. If there's a barrier about we don't know which drug to give you at the right time, let's do a clinical trial. If we know that the clinical trial is positive, but it hasn't come through into business as usual practice or day-to-day practice, it's about the evidence and the guidelines. If it's a barrier on the cost, well, let's go and learn health economics and cost effectiveness so we can help NICE make the right decisions. So it's always about breaking barriers and then to be able to innovate in drugs, devices, diagnostics, and now digital algorithms and AI. And, that's always about the next thing to help the patient. The quicker we can help them, ideally what we want to do is never let them become a patient, let them stay a person and do the prevention thing so well that they don't need to see us as cardiologists. That would be so nice.
Yeah. And I guess, would you say that sort of desire to improve those patient outcomes as early as possible has kind of inspired your sort of delving into digital innovation space as well?
It has. More and more of our work now is truly people's lives depending on digital technology. Emails not being missed, people's lives depend on it. Algorithms not booking your next test, or a digital click not leading to the right prescription. And so when people's lives depend on the conversations we have, you make sure that pathway is fixed if there's a problem. And that's the same as medicine. You give the treatment to the patient, well, you give a solution to the pathway.
Yeah, no, absolutely. And then obviously you've taken your interest in all of these sort of various interconnected fields, obviously, with this desire to improve patient outcomes and become an entrepreneur yourself. What's that transition been like between clinician? Well, it's not really a transition, is it? You're doing both, which is no small feat in its own right. What's that been like trying to do both at the same time?
It is hard to juggle, but luckily I've been blessed that the trust that I work at gives me time for research and gives me time for clinical. And actually it's that variety that really keeps you authentic, live, knowing what the front line is because you're on the front line, actually being able to understand, can the drug that you've created in a trial get down to routine practice? What are the barriers to stopping the translation of that technology, that intervention that works? And actually we're just flipping that to digital. Actually, and it's a shame that pharma companies don't do digital therapies more because their processes are so good and we're used to those processes for 30 years. So I've been in research as a research director for 10 years, but also doing clinical trials, designing clinical trials, health economic models for over 20 years.
Wow.
I was blessed to get into that area at the Brompton with my friend Marcus Flather in those days. And we designed trials that led to outcomes. And even as early as 20 years ago, we could see in a database of only 1,046 patients, we could see that if you were admitted to a hospital with a cath lab, there was a 6 times more likelihood you'll get an angiogram before discharge that would lead to a bypass. 6 times more. So that postcode lottery we broke by presenting that data and creating inter-hospital transfer systems for the national audit project called Making Moves.
Yeah.
That led to major change.
Yeah, that's so fascinating. As you've sort of become an entrepreneur in this field, and obviously you've talked about your sort of research background that's contributed to your understanding and the clinical trials, etc. I find that many doctors have, or clinicians have, these ideas and they want to fix the sort of problems that they see, and obviously you're coming at it from this angle. But not many take the leap into entrepreneurship. I guess what made you do it?
So this was partly selfish and partly for my staff.
Right.
It turned out that I was getting 200 emails a day and I would have stress with emails. And about 10 years ago, intuitively, I registered a website called Email Disease because I could see if you were not getting physical diseases, you'll get mental diseases, the overload, the techno-stress as we call it, the mental overload of the work that you're going to face when you come back from holiday. If there's 2,000 emails waiting for you, you're either going to do 2 hours a day like me on holiday before the family wake up to try and not disturb them, or you're going to come back 2 days early just to clear your decks.
Yeah.
Now, all of that stress needed a solution. It's a problem that needed fixing. And so the problem drives you. And actually, we did a survey called Shining a Light. We got 3,000 people all across the UK.
Wow.
I had to stop the survey early because everyone was saying the same thing, that, half of us are using our home time to catch up with work because we're worried about patient emails or we're worried about project emails or deadlines, etc. And so this idea that you work 9 to 5 or 36 hours or 37.5 hours, or if you're doing shift work as junior doctors, that's all you do. No, you go home, put the kids to bed, and then you go back and do emails. And then you wake up early to do emails on the bus or on the train or, etc. So it's a problem that's really widespread. And we're not really getting a handle on it, and we're creating a problem for ourselves that distracts us from human-human interactions.
Yeah.
So it motivated me to solve that.
Yeah, and you're so right. I mean, we are in the business of dealing with humans and communicating with humans, but we don't end up focusing on that enough in the NHS because we're so busy with all of that. I still remember in my days as a sort of young service manager, it was my first role as a band 7. I would have my BlackBerry at the time. I remember being in a bar and I was still sort of checking my BlackBerry for, a junior doctor's not showing up or whatever, and everybody's emailing. So it's so true. Just from my own experience of working in the NHS, the hundreds of emails per day per person is completely
untenable.
Inaccurate.
Untenable. It's not a healthy way to live.
No, not at all. And like you said, it's kind of like, people nowadays might talk about how if they receive a message on WhatsApp, they feel the need to respond as soon as possible. We feel like that in the healthcare system with emails as well, because like you said, there might be a patient at the end of that needs an action doing. That might be at the end of that email. So no, I completely, that challenge really resonates with me because I guess I've been there as well. And you use the word technostress. Could you just define that a bit more for us? Yeah,
there's several ways of thinking about technostress or digital working. On the wards, for example, a nurse doing a ward round in the old days, she'd have a trolley, she'd have a drug chart at the end of the bed, and it'd be quite straightforward to know which drugs she needed to give. And if she was a little bit late or having a cup of tea with the patient or having a conversation with the patient, those rare things that used to happen, it was okay, it was allowed. Now you've got an electronic health record system that requires you to do multiple clicks just to open that patient record, just to make sure you've given that drug. You have to tell them why you've been running late if you're running late, or if the patient's blood pressure's dropped, you're not going to give the drug, you have to give these reasons. And we've put all of this digital stress on something that was used to be a really straightforward, enjoyable way to interact. Same with email working and remote clinics. We're now at a process, gosh, I've only got 15 minutes to do that call, do that ambient AI or dictation AI, click on outpatient, inpatient, go to the next patient, log the outcomes, book the tests, etc. We're doing all of that admin ourselves. Yeah. There's no paper forms. You have to do 26 clicks just to get an outpatient clinic visit done with a patient. Wow. If any of those go in the wrong order, then of course you have to then backtrack and lose time to sort that all out. And that stress, it's not something human beings are used to. We didn't go into medicine to become digital or data engineers or to become computer keyboard warriors. We didn't go in with gaming backgrounds, etc. We went in with people backgrounds. Yeah. And so putting that side onto these guys, it's almost gamification. And actually the error rates are going really high. Scans are being missed. There's whole, waiting lists are constantly not even looped up to where they're meant to go to the person who's supposed to be booking it. The letters go missing because something in the printer output didn't get updated, etc. And so 26,000 letters will not go into the ether until we find that problem a month later. Yeah. And all of this adds techno stress on staff. And we think that digital distraction of the stress of getting something wrong when you're on the keyboards actually makes you quite anxious. Yeah. And that anxiety, most people in the NHS are stressed at a mild level and mildly depressed if you actually test them on a HAD score. And that's routine. Wow. It's not, if they go to India or if they go to New Zealand to work where we're still paper-based and things like that, suddenly the quality of life improves because they're people-based.
Right, yeah. It's interesting, isn't it? Here we are always pushing for, analog to digital, and you're talking about perhaps the paper systems people are less stressed in, whereas obviously we're sort of advancing every day on a digital front, but our staff are more stressed. And it's really interesting you talked about, I guess, how it's impacting, that stress is almost leading to more mistakes. We are trying to put in these solutions to fix the problems and improve patient pathways or indeed how fast they might be getting the appointments or tests they need. But actually what's happening is it's causing more mistakes to happen, more errors to happen. And, we are at Acumentis are absolutely in the business of actually fixing those kinds of things. And
that's another issue. In the old days, as a clinician, you could fix a problem you found. Oh, let's not give this version of the medication at this time. Let's give it in the evening so the digoxin level blood test can be done in the morning or in the afternoon. Right. Let's give digoxin in the evenings. We could go and fix those things. Yeah. We can't fix the software errors that we find. We can't fix the barriers. No. We can't fix the network's too slow. We can't fix my login's not working. You have to now depend on another industry of your IT and your digital tech colleagues and your engineers and your data engineers, network engineers, and your providers of software to fix those. Yeah. And it leads to that's going to take 2 days. Oh, well, we'll just have to accept that. And it leads to this failure culture that actually, yes, you report it, but you're now the 200th problem to be fixed, and your priority level for that fixing that, you can't see the x-rays for these patients in the way that you want to, is so low down the pecking order. Yeah, and most NHS trusts not resourced to rapidly respond to digital issues.
Yeah. I'm definitely on the front line dealing with these issues on a regular basis. So, completely agree. And so you obviously went out and did this big Shining a Light
paper. Yeah, absolutely.
So tell us more about that survey and what perhaps prompted it. I know you've talked about the reason sort of email came about and what led you to become the entrepreneur that you are now. But what led you to even start the survey in the first place?
So the survey was really worrying about how much of your time are you spending on communications, how much are you worrying about it, and how much is it intruding on your work-life balance. And it was for NHS staff. And actually it was a complicated survey. It's about 20 minutes. And I thought very few people will give me back that data. And this was midst of COVID, etc. We were thinking about this workload increase. One of my research managers said she's getting 1 email per minute, and she daren't even take a toilet break because she worried that when she came back, she'd have 20 more emails. And she's working flat out. She's one of these people that's so conscientious that she would want to try and clear her inbox, etc. And you can never do it because the more you respond, the more emails you get. So it's a self-defeating purpose. And so you can never get to zero unless you're ruthlessly never answer people's email, which is unusual. And that I thought, gosh, are we the only few OCD individuals that are like that, etc., that really care about every single email conversation or trying to help people? And I just thought, try and get 400 people and it would be really difficult. It might take a couple of months. Within a week, I had 400. And within a month, I had 3,000. I had to stop the survey because even hospital managers, even estates managers, finance directors wanted to tell me this culture is just becoming untenable.
Wow.
So you can have nurses and doctors, you can have pharmacists, physiotherapists, everybody is just getting overloaded by communication. 2/3 of staff were on their email either every minute or every hour. 2/3 of staff, even between clinics, between operations, they would be checking their emails. 1 in 2 said they use their home life. 2 out of 3 said it distracts them from their main work purpose. So that between, even if I'm in an MDT meeting, I'm actually checking emails at the same time rather than listening to my patient coming up for the multidisciplinary team meeting and then quickly distracting myself of one thing to another. And so it was, and 4 out of 5 people said they'd like a policy that actually it doesn't ruin their holiday. Often you get a complaint email on the first day of your holiday because you checked your email just as I'll just quickly check I haven't missed anything. And a major complaint comes through and that ruins your next week of holiday with your family because you're thinking about that complaint or you're thinking about the patient who passed away. Those are the things that we throw grenades at ourselves through that techno-stress channel.
Yeah.
And so that needed solving.
Yeah, no, absolutely. And many industries that I've read about have sort of done different things to deal with this kind of digital overwhelm. Why do you think perhaps the NHS hasn't quite picked it up until, obviously, we talk about air email in a moment?
I think one of the things about the NHS, it's a clinical system, unless there's a solution, it tries not to find a disease or a problem. Because then you're going to have to invest in solving it and actually put the money into solving that situation.
Yes.
And I think up till now, there hasn't been a solution. So let's not find that problem. Let's not talk about the problem. We all know about it. It's the elephant in the room. I can't go home at 5 o'clock. I go home at 7 o'clock because I'm conscious enough to try and finish X, Y, Z before I go home. Or I'll get home on time, but put the kids to bed and then start all over again. But if you ask any senior person or anyone with responsibility, anyone with a lot of workload, they are spending 90% of their time on their inboxes and their digital technologies, even though they're clinicians or even though they have clinical responsibilities, etc. So I think that in itself is humbling. But the NHS hasn't really cottoned on to that patient lives depend on email. It hasn't wanted to know that, but actually even in Lucy Ledbetter's case, it came through the testimony that her manager had lost track of her inbox and she couldn't keep up with emails. There were emails about concerns a year and a half earlier.
Wow.
And she hadn't seen those emails through the email overload. And that was recognised. Alan Hamilton, a young man who's a fit, healthy runner, wrote an email to his practice. I can't get through on the patches system or the system that you have. So I'm just emailing you that I'm more breathless than usual. And I had the chest infection, but the cough's gone away 4 days ago. What should I do? Do you mind if I'm sorry to email you? Says that. 3 days later, the practice actually responded back, we can't get through to you to book an appointment. And his sister went to his house the day after and he'd been dead on the floor for 4 days.
Gosh.
And the senior coroner, Alison Mulch, said, had that email been responded to in time, been triaged, somebody had picked up that phone to him and said, call an ambulance or let's get you evaluated, come to the practice, get antibiotics, he would have survived. So she wrote a future prevention of deaths report saying this was unacceptable, both to the GP practice that looked after Alan, but also to the Department of Health and Social Care.
Wow.
And so people's lives genuinely depend on emails.
Yeah, it's kind of a surprising thing to hear. You don't automatically think, what could help the NHS? Or let's sort out some email culture. But just those
Absolutely.
2 examples you've talked about have had such massive consequences in people's lives. So it leads us nicely into trying to understand your solution for perhaps all these challenges that we've talked about. So tell us a bit more about Air Email.
Thank you. So Air Email is a very simple tool that actually is intelligent automation. So it's doing all the things that somebody like me would do, triage the emails, color code them, flag them, actually highlight any tasks inside the actual text itself, and try and identify those patient-related emails. So if it's got a date of birth in it, if it's got a medical record number in it, if it's got an NHS ID in it, if it's got a task in it, highlight those tasks, find those patient-related emails and flag them up with a blue NHS colour, flag tag on the category bar. So first of all, we've added color to the inbox for the first time. Beautiful colors.
Yeah.
High priority, normal priority, low priority. It's even got a green one for unsubscribe in case you want to leave that unread if it's low priority forever, or delete that without even reading it. So it's trying to help you at the back end get rid of rubbish emails. But really, it's a task that says, don't drop the ball on those patient-related emails. It's so easy to find them. Our habit is to screen emails to find the important ones, flag them, and you do them later.
Yes.
And by the time you've done that triage, you're so tired you don't actually solve those difficult emails.
Yeah.
If we went the opposite way around and said, these are the difficult emails, I just need you to respond to those before you go home, then actually don't worry about the others. They may or may not be that important, etc. You'll have time later on to pick them up. But the big stuff's been dealt with if you deal with the high priority and the patient-related emails.
Yeah.
So Air Email does that. And it also has a staff well-being component. It even says to you, I've looked at your calendar, if you accept this meeting, you'll be spending more than 50% of your time in meetings that day. Do you really want to do that?
Oh, wow.
If you do,
So it prompts me to think about my well-being.
And if you do accept it, it'll put a comfort break, a fire break for 30 minutes in there, or 20 minutes. It will take that next gap and put a comfort break in there.
So it's almost like a well-being assistant as well.
It is.
At the same time,
And that's what we need. We need staff well-being culture, as well as staff efficiency and productivity improvement. And it does all of that with just simple, intelligent automation.
Yeah. No, that's so clever, isn't it? And like you say, so, sometimes the simplest solutions are the ones that are, exactly, elegant indeed. And so then you've taken this, as I understand this solution, and conducted an actual clinical trial with it, which is probably unheard of when you think of sort of, I guess, what you might refer to as a back end or a back office style digital innovation. So tell me more about why you did a clinical trial and obviously what were the results.
So first of all, the clinical trial expert in me, or the research director in me, said you have to prove something. You have to prove that it's efficient. You have to prove it does no harm. And you have to prove it's a worthwhile benefit. And it's a cost-effective benefit. So that is ingrained in me for drugs and devices and diagnostics in the cardiology culture. We wouldn't do therapy for heart function drugs unless you've got a clinical trial that's absolutely airtight. So we thought we'll do exactly the same with this, and that will be the evidence base that commissioners need to make these decisions. So we actually had to build 3 software. We had to build one software that is Air Email, the intervention that does something. We had to build a back-end software to monitor you before and after the intervention. So it's actually looking at your behavior patterns in the background, so in silent mode, so you haven't actually switched on the features, so we can see the difference before and after. And we had to build a dashboard to show people what we'd achieved after we'd actually put the intervention in. And at the executive level, you need a dashboard for the commissioner or the purchaser, etc. And then we did that trial. We actually did it very robustly. So you have 2 weeks. It's watching you. You've loaded a software, back-end software, now Microsoft Outlook add-in. And it's watching you and seeing your behavior, seeing what you're leaving unread, seeing what you're responding to, what your response times are. Then you do that 20-minute intuitive training by yourself. You can get help if you need it, but it's very straightforward training. It's quite intuitive. And then you have 8 weeks of the clinical trial. And then you actually take the software away for the next 2 weeks and see if your behavior goes back to. There's a rebound effect that you went back to where you were, or actually you do not need the software anymore. And the results were spectacular. 400,000 emails, 66 people
in 8 weeks.
In 8 weeks of time the people are in it for 8 weeks. The trial actually had to go over a year to get people onboarded and so forth. They're self arriving to the clinical trial. Whoever's got a problem with clinical inbox, please, we've got this trial. Would you like to participate?
Got it.
So they're unselected. You had nurses, finance directors, estates directors, doctors, junior doctors, senior doctors, CCIOs, CMIOs. You had very senior people inside the trial. And actually the results, our aim was a 2% productivity gain, 2% faster response time, 2% more patient-related emails.
Which is I guess, one of the NHS priorities.
That's the priority, 2% productivity gain. Turns out we smashed that. 26% faster response time.
Wow.
18 hours, so 2.5 working days, response time to high-priority patient-related emails. Wow. We left 1/3 less emails unread, including patient-related emails. 1/3, 36% less unread.
Just by prioritizing it in an appropriate way. Yeah.
And for the first time ever, a software led to staff well-being impact with a 13% reduction in anxiety within 2 weeks of using our software on the hospital anxiety and depression score, very well validated. Our staff said, I'm 13% less stressed, hitting a p-equals 0.01 value, which means there's a 1 in 1,000 chance that's a fluke result.
Right, wow.
Staff were truly, 1 in 3 staff said, you've just completely transformed my work-life balance at home. You know, I actually have a better way of getting home at 5 o'clock on a Friday and my family can see me, etc. So it's absolutely bizarre that we hit these results in all 3 areas. Clinical safety improved, patient productivity or staff productivity improved, and staff well-being.
Wow.
And it's the first software that's ever been tested so rigorously, but also to demonstrate those sorts of results. And there are a number of firsts that we managed to do. And the trial was undertaken at a leading NHS institution, Royal Free, in London, which is a very large staff base.
And it's really interesting because you've got this result across all these different staff groups, not just clinicians or sort of managers. It seems to be across the board that it has had this kind of impact. Were there any particular staff groups that, I don't know, felt greater improvement than others?
Nurses and doctors, senior doctors, because the more senior you are, the more unread emails you've got.
Yes. Well, people are chasing you down for various responses, aren't they, all the time?
They are,
then?
and they hadn't realised once they started identifying those emails and looking back at the things that were being found. We did an audit of just 12 emails for one consultant, and within the first 2 emails, he'd found a patient he had forgotten to book a liver cancer scan for.
Wow.
And he also found that he'd forgotten to do an insurance report for a patient, and they'd been waiting for months for this insurance report, and he thought his secretary was doing it, and the secretary thought he was doing it. And he just, 2 pathways that were immediately within 12 that he found that he hadn't dealt with.
Yeah. Yeah, because you're right. Like, if I've got 100 emails coming through, how do I quickly establish which one needs my attention when I've got 15 minutes at the end of the day to try and address it? And that's the kind of thing that you're solving with our
as
email.
As human behaviour, we do the easy ones quickly. We don't do the hard ones.
Whereas
it's hard to do the big rocks first. So as human beings, the more stress we're under, the easier we want our life to be.
I know that feeling. That's so amazing. I mean, it's such an impressive software, but like you said, simple yet elegant. I'm curious, why do you call it Air Email?
That's really interesting. I mean, first of all, the salesperson in me, although I'm not a salesperson, would say having something with A is really important. And it's very obvious that it's about email.
Yes.
But actually, the clever idea that we had was that it's got intelligent automation in the AI, but in the future, it's got artificial intelligence. So if you use AI through research to help email, that becomes Air Email.
Yes. That's amazing. I mean, I sort of racked my brain trying to work it out myself, and I probably couldn't. but all that makes real sense. So with these amazing results,
the NHS DigiWell trial, we called it. DigiWell, digital well-being.
Digital well-being, indeed. And so these amazing results, and this sort of simple, easy to use, and really sort of impact generating software. What kind of traction have you seen since completion of the study?
This is where it gets a little bit difficult. The NHS always has a hard time not adopting technologies. It's always had a hard time adopting drug technologies. It used to take us 8 years from a clinical trial to get through NICE to make sure it's through the guidelines and get that adopted. It would take 6 years before tests, standard blood tests that were now going to be able to tell you've got a weakened heart, NT-proBNP would be picked up, etc. And it's exactly the same for digital technologies. It's really slow in picking up digital technologies, even when you've created the evidence base. What they look for is central funding. If there's a central call and a central fund that says, hey, we need you to pick up this electronic health record system because here's the central money to do it, then you'll suddenly get an electronic health record system purchased. But when you've got actually the electronic health record systems and other contact communication tools have got holes in them, here's a solution to fix the holes. But there's no central funding. We'll have to wait till there's an underspend, or we'll have to wait till there's an opportunity, or can you get money from charity, or can you get your own money from a grant? And so the NHS is very hard at these subtle, soft things. You almost need a National Institute of Clinical Digital Excellence saying something about these are mandatory. This appraisal system is mandatory. This ID validation system is mandatory. This email safety net for patients is mandatory. This out of office component so that emails don't get lost when you're away for 2 weeks is mandatory.
Yeah.
And there is no culture like that at the moment in the NHS. So the purchasing and the commissioning has been hard. We need to find people that see the pain points. They've suddenly had to pay large lawsuits or large out-of-court settlements because they've not seen the email that said book this cancer scan, etc. Or this patient's not doing well with this drug, change them over. And they're seeing that pain point and then suddenly going, we need a solution for this.
Yeah.
So when that pain point hits somebody who's got funding and it's an executive board behind it, there we're seeing innovation traction. So we're seeing that use. We're seeing for radiologists, we are the first software in the world that you can go straight from Outlook to click on the right-hand side, find a drop-down on the medical record number, and go straight to the patient's x-rays or straight to the patient's medical records. First software in the world to do that. So we're seeing traction in radiographers and radiologists. So our pilot, our next pilot in a large trust is for the radiology consultants because they get so many emails per day asking to report and scans. Imagine if they can go straight to opening that patient's
just reduces
x-rays.
those number of clicks
friction
you've talked about.
And human errors.
Yeah. No, that's really interesting. So I mean, that is a story that I've heard many people talk about, that, great innovation, great ideas, great results. Not everybody has a clinical trial behind them, but they've got some evidence, but they're finding it hard to either implement or get traction in the NHS. And so you've talked about this sort of National Institute of Digital Excellence. I guess how do you see a body like that working without stifling competition, I guess? If they did say you must go and use email or another solution for another particular niche problem, how does that work when the competition might
So we
get
worry
stifled?
about that,
Yeah.
but drug companies don't worry about that. You've got 4 statins, 4 blood thinners, you've got multiple ACE inhibitors, and there's space for everybody.
Yeah.
And it's about the relationships and the evidence base and the niche that you're solving. There's always a particular flavor. The pediatric solution might be different to the adult solution, might be different to the women and children's, might be different to the HIV category because you want some confidentiality, etc. Now, we're lucky. We're one of the first ever. We are the first ever clinical help software in the world, and so we don't believe that we're the last. We believe there'll be others that need to help us or help do this work. It's all about improving our work-life balance while we're helping our patients or our population. And so I'm not worried about stifling competition. What I'm worried about is the opposite, not adopting a proven solution, the translation. We know Wes Streeting and Peter Carl, they're really focused on adopting digital tools. Those digital tools that are evidence-based should have a fast-track solution. And those fast-track solutions should be, let's use it at 3 large institutions. If in a year's time nothing's broken and actually efficiency gains are really quite materialized as they were in the clinical trial, then that's proof that we need to disperse this across all 200 hospitals and 35,000 GPs and so forth, because it's proven its ground. It's that middle step that's not there. That middle step of, okay, let's do that bit. We'll support you to do that first scale up, regional scale up to 3 hospitals, make sure it really is proof ground, and then we'll distribute it really quickly. That's what's really needed, and I hope that our executive teams in the NHS will see that, the John McGee's of the world, NHS Marketplace, NHS.net, these cultures, but the funding has to come into this area.
Absolutely. I mean, a lot of solutions that are coming into the market at the moment through innovators in health innovation networks and so on and so forth are all about prevention. But what I keep hearing from these founders, much like this conversation, is, but where is that central funding for prevention? So it's one of the national priorities, but where is that central funding? And it almost feels like if you don't have central funding, how do you take this off, and how do you get that traction? And
it was really sad. One of a really good software company that's doing really well at the moment. I was meeting them at the Grow London Global Digital Accelerator, and I was saying, I'm really worried about, look, we've spent this much money, and so far we've made a fraction of that in revenue, etc. And when will we ever get to that point? And actually, it was reassuring. He said, well, actually, I spent $3 million to get my first £20,000 worth of sales. But it's so sad that he had to go through that pain of raising that much capital, that much hanging on to that aspect. And he was fortunate. He was really successful with grants and so forth. But, you worry about the responsibility of people's funding going into this. Now, if you're deep pockets like pharma and you can last it out for 50 years, etc., and you've got that sustainability, that's great. But most entrepreneurs, most innovators in healthcare, most nurses, physiotherapists, whoever's innovating, they don't have access to that stability. In the NHS cycle, just to get a contract might be a year to get a contract, even from the evidence base.
Yeah.
Can you last the company out for that year while you're waiting?
Yeah, absolutely.
Will you ever catch up with the investment?
Indeed, and that is why the big players often end up becoming the staple product in the market. And quite frankly, it feels like they can get away with not innovating.
Yes.
They can get away
It's
with
a monopoly.
keeping
It's
keeping
a
the same.
monopoly.
I mean, some of the biggest CPRs, not to name names,
yes.
are roughly exactly the same as they were 10 years ago. That kind of value is just not coming from them.
And we're fixing the holes of those electronic health record systems.
Precisely.
We're fixing the lack of, transferability of data from Epic to Cerner to EMIS to System 1 to, etc.
Yes.
We're fixing the gaps between them all.
Yeah, and indeed, the people who are fixing those gaps, they are the ones who need the support.
Absolutely.
And that's perhaps what we're saying is challenged in the
and
the
that's where
NHS
I
marketplace.
And that's where I think a digital secretary of health
Yeah.
would be a really interesting type of position with that portfolio.
Yeah.
And I think that's where we should be going. There should be a digital health czar,
Yeah.
as there is a cardiovascular czar, prevention czar, diabetes czar.
Yeah.
I haven't really. Vindavark is doing amazing as our CMIO for the NHS, etc. And there are colleagues that are supporting him, Ming Tang, in the data office. They're doing amazing things.
Yeah.
But I don't know that they've got the budget to be able to innovate inside the NHS.
Yes.
Now, in a commercial hospital culture, take Israel, for example, they will support their entrepreneurs and actually then sell that technology on to others as a hospital that's making profit.
Right, yeah.
And they can just spin out
In that
and
kind of
get
partnership
$300
model.
million profit just from 2 innovations that their doctors on the ground, nurses on the ground made in their hospital and validated in their hospital.
Yeah.
And they go out and spin it out. But they give an appropriate share to those entrepreneurs. We don't have that culture.
No, we don't. Budget holders in the NHS who commission these types of products and innovations, they might not always see how an email management software might have clinical priorities attached to it. What would be your argument to them?
So the budget holders, first of all, always ask for the evidence base. And we've shown through NHS clinical trial, every day in the NHS, there are 50 million emails. Every day.
Wow.
At least 5 million patient-related emails will go through the NHS every day. Imagine that 5% of those will never be read.
Gosh.
Now, we're talking about 250,000 emails.
Yeah.
Right?
Per day.
Per day. Per year, about 300 million of the 7.5 billion emails will never be read per year. Within that, if you imagine that 5% of patient-related emails, that's 15 million emails, patient-related emails that will never be read. If only a fraction of those lead to true harm, 5%, that's still almost 1 million people. And our software reduces that by 1/3 immediately within 2 weeks, while improving staff well-being. So the problem with the budget holders is not that they get it within a couple of minutes. Some of our best pitches have been to CFOs who've just said, but I get this. I've just had to pay a lawsuit case, etc. The question is, can you get it integrated and can we decide who it needs to go to? And then when it comes to the pinch, it's not electronic health record system based. It's not, but we're trying to create a single source of truth inside the EHR. Why is email necessary? Well, a GP can't go inside your electronic health record system and send you a message. They can only send you an external referral or an email, and mostly they choose to send you an email. The practices send me emails every single day. We try not to fragment the single source of truth record, but actually what I have to do is when I reply to that email, I have to send a copy to my secretary to scan it in and load it to the EHR, just so the single source of truth. Now, all of that is just absolutely time wasting. And one of the things that I think budget holders don't really get is how many mundane, menial tasks our healthcare professionals are having to do. Wasted time of scanning something in that's already been declared just to keep a single source of truth. So these are holes that we're fixing in EHRs. They can't see that. They see an EHR budget. Why do we need a separate budget? And actually, where am I going to find that? And I'm supposed to be finding savings. They don't see that the NHS footprint of the server, by reducing 5% of unread emails, just deleting them, the low priority and unsubscribe, Actually, not having 3,000 emails clogging up your inbox that are unread every day, 600 less. Okay, the next week, remove another 600, etc. That whole green footprint, they don't see the real ramifications of why it's a priority.
Yeah.
They see it as well, why do you need AC? But temperature control in the wards is absolutely mandatory.
Yeah.
And in the pediatric PCU, pediatric ICU, you need temperature control. They can see that, but they can't see temperature control for the rest of the hospital until COVID hits.
Yes.
And all of a sudden you realize that actually this will cause worse chest infections, this will cause, etc. So it's prioritization. I think they're really good people, but they don't, unless they feel the pain point themselves, see that they're missing patient-related emails, they don't always get it, or they don't prioritize to put funding into it.
Yes.
And also they don't get the feedback, oh, this is really working. They need to see that at the end of 1 year, they've really achieved 200,000 patients more have been dealt with.
Yeah.
Right?
Yeah, no, absolutely.
And actually the patient report outcome measures should come with it.
Yeah.
So we've built a system in the dashboard that says, hey, today at your trust, you've got 50,000 unread emails, more than 5 days. We're going to nudge the 1,000 clinicians that have got those unread emails, and they're going to tell us on that nudge whether it was useless, whether it was important but not patient-rated, or it's important and patient-rated. And so the dashboard will then say to you, actually 200 patients benefited from those nudges from yesterday's nudges.
So it's live evaluation
Live evaluation, live dashboard. So the dashboard is all built to do exactly that.
Yeah.
When they get that sort of data, they're much happier that they can see. And actually, if response times come down to patient-related emails for the trust, that's wonderful reputation.
Yeah, no, absolutely. It's really interesting. You've talked about, obviously, clinical trials and evaluation in this way of the software live as well. Do you feel that the NHS does enough evaluation in general of solutions that come into its space?
The NHS does evaluations, but how it socializes and story tells to everybody else to get on board and actually utilize this, that translation of a solution from one place to many other places, that's the hardest part.
Yeah.
So I can prove a drug trial here, and I can prove it works in this particular space, but getting it used in all the other 220 trusts, getting it used across all the primary care, that's the hard part that we're really slow on. So adoption, storytelling, the convincing, the conviction. Okay, my neighbor's using this, they've seen a benefit. Okay, I'm going to use this, etc.
Yeah.
And that movement of, well, it's a done deal. It should just be a regional approach. It should be a national approach. So I think NHS Marketplace might be a place like that. And I was told John Quinn, who's now leaving the NHS sadly for a time being to look after family, but he's really into the idea, the vision that actually people shouldn't have to recreate the solutions.
Yes.
Caroline Clark, the CEO of London, she's also said, why are we reinventing the wheel all the time, making people wanting to prove it again and again and again? Yeah. And we lose so much energy from clinicians and the founders and the engineers and reproving that.
Yes.
I think that's a wastage.
Yeah, no, absolutely. And I guess, just going back to your point earlier about having that sort of National Institute of Digital Excellence as well, because one of the reasons why we even started this podcast was because I've been in this space for 10 years, and I don't feel like I know all the innovations that are out there that are working and have been evaluated and are evidence-based. So when we work with clients and we want to help them solve a certain problem, which could be solved digitally, I don't always know what should be sort of suggested to them. So if I don't know, and I'm in a commercial organization, right, do the NHS know about these kind of solutions that are out there?
Yes.
And that sort of whole communicating that evidence-based success of innovations is perhaps, it needs more of an oomph behind it.
So we're good at finding the solutions in accelerators. So, for example, we're blessed. Air Email is part of Digital Health London's this year's cohort 8. Yeah. And actually this week, we just got announced to be Grow London Global Accelerator.
Fantastic.
So we're cohort 6. Thank you. Two accelerators who've looked at our evidence base, looked at our model, looked at our problem solution statement and said it's a big enough, important, impacting. So we can find them and put them in the accelerators, but what we then are not doing is making sure those accelerator companies get their contracts really quick enough
Yes.
to continue not only surviving but thriving
Yes.
to the next level, so that they've got funds so they can innovate more and fix the next problem that somebody's saying, can you do this as well?
Yes.
So we've just had one where the parking team are not responding to their emails, and actually the stress on the parking team leads to them leaving, quite quickly turning over.
Right.
And then the fines continue escalating because they haven't taken off that parking fine that was given to a patient or a staff member unnecessarily.
Right.
So the disability blue badge was there. They forgot to bring it to the desk, except by accident, but the blue badge was on the dashboard. But no parking eye has given them a ticket, etc. The staff member came in as an emergency on call. They're allowed to come in and don't have to pay for parking that on a Saturday. But the parking eye gave them a ticket. And of course, that ticket escalation, we're going to send the bailiffs around. Now, these people are not responding to the emails, and they don't have time to pick up the phone to all of those complaints. That's putting so much stress on the staff and the patients.
Yeah.
So half the time the patients just pay the money just to get rid of that stress.
Yeah.
But staff feel really aggrieved about that. They've paid for parking and they're now having to pay a parking fine. Now, the use case would be if that email had a hyperlink directly to Parking Eye and their license plate number to their payments of their thing, then immediately you could very quickly deal with that email and actually resolve that before the next 6 emails from the same person saying you haven't dealt with this.
No, absolutely.
So I think that sort of evidence-based and use cases come through, but how do we then get the funding to flip and pivot to include that solution?
Yes, absolutely.
Where's the funding for that?
Yeah.
So people don't see that efficiency gain
Yeah.
and actually take the risk unless somebody's life is depending on it. And even then, they're still risk averse.
Yes. Well, I guess, that's definitely how I describe the NHS. Very, very risk averse. But that's really interesting. And so we've started talking about funding ever so slightly now. How is Air Email funded?
We were very blessed. We had a co-founder, Tim Webb, absolutely wonderful benefactor, who actually helped us do the first part of that Air Email, all of the software build and so forth. He actually was a tribute to his father. His father, actually, he couldn't get through email responses to his GP. And of course, there was too much email traffic. GPs always worry about their email traffic, they can't cope, etc. So often they'll leave those communications to the front staff or might not get to those communications. And he saw the problem instantly. Within 5 minutes, he saw that problem. And he said, that's a big deal. If we can help that many lives, 7.5 billion emails and 300 million unread emails per year and 1 million potential patient harm. When he heard that, he put the first level of funding in.
Brilliant.
So at that stage, we've been able to build all of that with that seed funding.
Great. And do you feel like you'll be going into some kind of funding round for scaling up, or do you not?
We will need to do that.
Yeah.
If we can't get our contracts in time. To be honest, we should be able to stand on our own 2 feet because the solution is intelligent automation. It hasn't required a huge level of AI in it.
Yeah.
But at the next level, when we iterate AI to make things even better, to help context read those emails, to actually give an early answer, draft response to a difficult email, or even to automate that, hey, a patient has said they want to know about their date for surgery. Actually, I've just looked it up and the date for surgery at the moment is scheduled for this. We'll just reply that email back to you. You don't need to reply to that email. I've done it. Or if the patient says, do I need to starve for that operation? Well, actually, here's the guidelines on 4 hours of starving for food and water. Here's the draft response.
Exactly.
Imagine if we could get to clearing out some of those emails that could be answered really nicely and automatically. And if you don't like this answer, here's somebody you can call and actually speak to a human being because they're now free enough to have time to talk to you. They enjoy talking to you.
Yeah, no, fascinating. I do see that as a really value-added addition. I can promise you there were plenty of emails that I used to get just in operational management. I wasn't even a clinician. That could be dealt with in that kind of a LLM AI model, to be honest. So that would be a great development.
So actually, about half of our people who've really said they've enjoyed our software are administrators. They're not clinicians. Because they're dealing with the on-call waiting list, they're dealing with the clinics, they're dealing with. So actually, we think that the team, the managers themselves are the most important users of Air Email because it just frees up their time to really troubleshoot properly.
Yeah, no, definitely. You have recently started on the Digital Health Accelerator, Cohort 8, as you said. You've also gotten onto the Global Accelerator Program. How do you think they're going to help the next steps for Air Email?
So there's two parts to the accelerators. The accelerators are really good energy.
Yeah.
You've made it, you're actually meeting like-minded individuals.
Yeah.
And the bits that I'm really enjoying is talking to each other as companies and helping each other out. Because we all face the same problems. The idea that somebody had to spend 3 million just to get their first £20,000 contract, I would never have known that unless I'd been in that circle to be able to tell them that. I wouldn't be able to share my difficulties that actually we've got all this investment that somebody put in, and actually I'm still struggling to return anything on that, any of that investment if we can. We can't share those things except in accelerator groups that are also doing the same struggle. Yeah. And so you get that shared confidence, that shared knowledge to be able to open up and help each other. Yeah. I've been able to help 3 companies so far to try and understand, hey, that pitch could be differently, or have you thought about doing a clinical trial? Yeah. Or can I introduce you to pharma companies, or can I introduce you to these people, etc. Or that pitch went badly because of X or Y. It wasn't anything to do with your pitch. It was to do with their priorities, that their HR priority was so big. Yeah. So giving people that sort of cross-communication, that cross-support is really good. Yeah. And the accelerators can bring key players into the room to whom you're pitching. Yes. So that's quite good. But I think an accelerator that leads to contract acceleration, commissioning acceleration is still needed. Yeah. I've been challenging my accelerator team to know when underspends are occurring. Yes. That opportunity, that pain point opportunity with an opportunistic, hey, we can resolve that pain point today and get that first year's funding into that. And they often don't know. They are not privy to that sort of level of information of the true decision making of things that are not predictable in the NHS. Yes. When do they bring that new innovation in? Yeah. Okay, there's X, Y, and Z conditions occurring, but they only occur for 1 week. Yeah. If you don't get that window, sorry, you've lost it for another year. Yeah. It's not just you've lost it for a month. No, you've lost it for another year. Yeah. And so I think that's where I'm challenging the accelerators to know about that aspect of commissioning and contracting. They're very good at sifting out that you're the right solution for a right problem. Yes. And you're a good team, and they value you, and they can demonstrate you, and etc. And they can connect you. But actually following through on that commission, that sustainability. Yes. Doctor, for example, has done really well. There's some companies that have done extremely well, Accurix, etc., through accelerators. So I think there is that solution. But also, the smaller companies should all get that same level of help. Indeed. Or be told to transform. Yeah, yeah, no, absolutely. Pivot. I think that's such a great, I guess, recommendation to be aware of where there is budget as well, or an underspend, whichever way you look at it, because I do often find that we're having conversations with NHS organisations who love our product or our service or any of those things. And they're just like, yes, but we don't have the funds at the moment. So when they do have the funds, it would be great for a conduit such as a Health Innovation Network to be plugged into that kind of knowledge and to be able to share that with the right type of innovation that organisation might be looking for. But yeah, I've never thought of it that way, but that is a great idea. I hope somebody is listening from Health Innovation Network as well, and from the government for that matter, so that they can come up with a digital czar, as you called it, and a national digital excellence body as well. So what's next for Air Email, would you say? So you are now on these 2 accelerators. One is a global one. So what is the ambition there? I think the ambition is, can we tap into that huge volume of email to bring AI to really bear? Copilot is too much. You can't just switch on Copilot, and it takes ages to learn and to trust it and to know what it's doing, etc. It's quite a beast, etc. But these simple intelligent automation tools can be seen. It's intuitive. You know what it's doing. You trust it. And in the healthcare space, that trust is everything.
And there is no black box.
There's no black box. Yeah. So you can change a directory for an orthopedic consultant that is interested in prostheses and infections and things like that. A pediatrician is more interested in children getting whooping cough or something like that, rashes, etc. So you can change the directory really quickly. So it's about embedding. we're very blessed that we have found a mechanism to reach all 1.7 million inboxes and 1.4 million staff in one tenant.
Right.
So we have the ability to reach everybody with a solution that works. That's really rare, and that took us a year and a half to navigate the ability to do that safely. And we're through Microsoft Outlook, so we're encryption protection through Microsoft and all of those things. So the safety side of it is all there.
Yeah. So it integrates with all the things that it needs to integrate
on
with.
any Outlook tenant. And GPs are on Outlook tenants.
Yes.
Pharmacists are on Outlook tenants.
Yes.
A lot of people in the US are on Microsoft tenants. So for us, wherever there's a Microsoft tenant or large tenants that could be benefiting from this triage mechanism to make sure patient-related emails are surfaced, the right-hand side hyperlinks, that benefit that you get from Outlook to a clinical system, that's partly what we want to do, which is the stuff that creates sustainability. Yeah. But the next level is, okay, what are the small but clever, intelligent automations on drafting an email for you? Or what about the ability to write to disconnect? That you're going on holiday, but that patient-related email should actually divert to somebody like you that's on call, that has the workload capacity to do that.
Indeed.
That matching of work to capacity is the next thing for us. That's a big deal for me. We shouldn't have to look at our emails outside of our working hours, but they still might need dealing with, and they can go to the next person on call. That's a big deal. That diversion, that appropriate diversion, and letting me know that that's happened, so I don't have to worry about it. So there's a lot we can do on knowing. What AirEmail also wants to do is understand you, that if you're not on leave, but you've suddenly left 200 patient-related emails unread for 10 days, what's going on? Have you had a breakdown? Have you had a stress moment? Have you lost track of your inbox all of a sudden because your pattern has changed? Are you techno-stressed? Do you have email disease? Or is something, for example, an eye infection? For 7 days, you can't use your computer very well. And all of a sudden, from your 200 responses a day, you've gone down to 2 responses a day because you've had an eye infection. Nobody knows that. And if we let them know that actually this traffic is going to be slowed, you need to go somewhere else, here's something else. That would be so useful for us. Protecting you as a staff member.
I mean, I guess somebody once said to me as well, NHS is the business of communication. And those kinds of solutions sound really helpful in those situations. Like you say, if I'm not responding,
your staff well-being is hurt.
So and there is this well-being assistant, as I keep calling it, in email, which is not only looking out for me but also perhaps helping me acknowledge that there is, I will be slower in responding. Absolutely. And if an AI just sort of creates that draft, it's very unlikely, when I'm going through something like that I will come up with my own kind of draft or sort of automated response or whatever. But if there is an AI assistant that does that for me, I
and
can
validates it in a clinical trial.
Yeah, well, yeah, exactly. Right? Yeah, that would be really great. Yeah, so I can totally see the benefits for both the people who are receiving the email and sort of suffering from that techno stress, but indeed helping those people communicate effectively outside as well. So, exciting stuff for email.
We also think there's space for people like Microsoft to really be helping us in that sense. They won't want to become a patient-related technology because it might mean medical device status.
Yes,
but that's something we want to take head on.
Right.
Because we're improving that situation. We know the risk parameters around the potential of missing patient-related emails versus not. We've improved that dramatically by 1/3 already with intelligent automation. Imagine what we could do with better tools, right?
Indeed.
So we want to go there. We think every patient contact counts. Or person contact counts to the healthcare service. In banking world, hey, this is your phone call. We might record it. Or it's an email. It's logged forever. That audit trail is there.
Absolutely.
In legal world, it's there, and people are getting paid to just read that email, etc. But it's not there where it really matters. Your life depends on your health and your healthcare, and yet we don't take these seriously.
Well, I mean, it's so true, isn't it? In banking, even supermarkets, all of these other sort of private industries are so far ahead in the way they communicate with their customers, and indeed their staff. But we are certainly we've got a long way to go in the NHS. So yeah, I'm very excited about the things that our email can do for staff and patients. So if anybody's listening who is also a healthcare professional and wants to solve a problem that they've identified, what would be your advice to them around where should they start?
So I think the good news is that, again, on a lot of platforms, there's a lot of people that are willing to A, share their experience,
Yeah.
B, have already shared their experience, they've already documented it. Things like this podcast, for example, are really important. These podcasts, a lot of junior doctors and nurses are now getting into the entrepreneur space.
Yes.
The only sad thing I feel is that they're having to leave their clinical work to be able to give it their shot in the digital world. And that's not fair on them. They should be able to do both, because being on the front line makes that product better. And on the other hand, they need the speed of the product iterating, so they should be able to work together and there should be the funding to collaborate and quickly do that. So I think being amongst other people and talking to them, really important, reading up on this. Is there a do-it guide? Is there here's all the problems you'll face, they're insurmountable, and actually you'll probably learn more from your first mistakes. A lot of entrepreneurs have said, well, my first company, I had to move on and pivot.
Yeah.
And I learned so much from that. And it was their ability to get past not seeing it as failures, but as experience that allowed their next company to be more successful and their third company to be the most successful.
Yeah. No, absolutely.
And so have a thick skin, know your purpose, don't let go of that patient impact that you can have as healthcare staff. Don't never let go. That's what really brought you into healthcare. Stay true to your roots in that sense is something, but you can do both.
Yeah.
And actually both might be slower, but might be better.
Yeah, no, absolutely. Like you said, if you're on the front line, you're likely to understand the use case of the product so much better as well. And practically speaking, so you've given some great advice around thick skin and knowing your purpose and perhaps the sort of end goal that you've got for patients in mind. Practically speaking, if you were starting this company today from day zero, what would you do first?
I think the hardest part is thinking that it actually takes 4 or 5 years to get that first sale, even if you go about it all the right way.
Yeah.
Because the NHS is so slow in permissions and integration and clinical trials, all those sorts of things. So not being naive in that idea that it will take time.
Yeah.
And that then will take funding. And having that funding space, that ability to breathe, being able to connect with many people so that the opportunity lands and you're ready for that timing of that opportunity with your solution. Timing is really important.
Yes.
Is the timing right for air email? Yes, because email volume is just going ballistic. So this is the right time. Is the timing right for well-being idea of disconnecting from digital technologies? We're seeing youngsters, they're so digitally overloaded and addicted to their digital that when you take it away or do something with it, it harms them. So we're now seeing that this is real, these harms, these cancel cultures and things like that. People are, oh my God, I'm not on the WhatsApp groups anymore. Somebody's removed me.
FOMO.
And children are actually self-harming from things like that. So these are real things that are going to happen.
Yeah.
And so we have to be able to create these real solutions to solve them.
Yeah, no, absolutely. And last but not the least, looking back at your whole journey, because you've been doing this for a few years, if you could tell yourself from 5 years ago or any point in that time to do something differently, what would that be?
I think a lot of the times we meet amazing people in our life.
Yeah.
I'm lucky I've got Liba Stones and Martin Green and Tim Webb and people like that, etc. And you don't know when you can turn those conversations, that energy into work solution.
Yeah.
And I want you to try to have that idea that as you go along in life from the age of 18 onwards, you think about who you want to work with for the next 10 years. And you try to bring that together. You try to bring them in that room with you for the right purpose at the right time with
Yeah.
the right funding, attitudes, etc.
Yeah.
Of course, there are more mortgages and all the expenses and things have to be looked after.
Mm.
But I've missed out on keeping those brilliant people close to me.
Mm.
Where I've succeeded in the NHS, my research teams and so forth, absolutely miracles have been achieved.
Wow.
But we don't do that on the entrepreneur side as much. We do that in a cardiology team, in a cath lab team, in a cardiothoracic team, etc. We're very good at doing that in the NHS. We know exactly who needs to be in the room to get that best outcome for that patient. We don't understand how to do it for companies, or we don't have the conviction to do it for a company.
Yeah.
Now, when you look at these successful entrepreneurs, for them, people, projects and processes and priorities are the key, but the people come at the top.
Yeah.
And I think that's what I'd tell myself, to have a notebook that says, I want to work with this person for life.
Yeah. Write down whoever you meet who you think could sort of join you in your purpose.
Because that energy just stays, right?
Yeah. And they say, don't they, you are the sum of the 5 people you are around the most. And mostly we're around the people we work with, not even so much our families.
Absolutely
right. So it's so important, as you say, to hold on to those people who you can almost immediately align your purpose with.
Correct.
But yeah, no, I couldn't agree more. Well, thank you so much, Ameet. It's been an absolutely fascinating conversation.
Bit cathartic, sorry.
Yeah, a little bit, isn't it? For me as well. I've had a bit of a sort of letting go as well. But no, it's so nice to meet like-minded people, and you're doing something so amazing and interesting, and as we said, very, very elegant to solve the challenges for staff and patients. So I'm really excited to see what Air Email does next. Thank you so much for your time today.
Karina, I think that's been one of the best sort of expositions of the journey that I've ever had. And, so I thank you for navigating us through that.
Oh, thank you so much for your kind words. Well, I hope lots of people listen to this podcast because, I'll be going back and listening to it again as well. Thank you once again.
Cheers.
Thanks so much for listening to Inside Health Innovation podcast today. If you want to hear more of similar fascinating stories about innovation in the healthcare space, please do subscribe to our podcast anywhere where you get them. And I look forward to seeing you next time. Thank you.